Hi, my name is Dr. Karen Simmons, and I'm a faculty member from the University of North Dakota's College of Nursing and Professional Disciplines. And welcome to the first part of a two-part series on dementia. This presentation, Part 1, will focus on the various types of dementia. Part 2 will focus on how to care for someone with dementia. This presentation is supported by the Spirit Lake Senior Services Program, of which Vanessa Thomas is the director of, and it is part of an ACL grant titled Dementia Capability in Indian Country, with Iris Walking Eagle serving as the Dementia Project Coordinator. It is also co-sponsored by the Dakota Geriatrics from the University of North Dakota's Rural Health and the University of North Dakota's College of Nursing and Professional Disciplines. According to the Diagnostic and Statistical Manual, the 5th edition, or the DSM-5, dementias are now categorized as neurocognitive disorders. So our objectives for this presentation is to understand the criteria for neurocognitive disorders, identify the differences between the cognitive, functional, and behavioral changes of normal aging and those associated with mild cognitive impairment and neurocognitive disorders. We want to identify the signs of early stage dementia and identify the signs of middle stage dementia. We're going to discuss the 4 most common types of neurocognitive disorders, recognize the prevalence, risk factors, signs and symptoms, and rate of progression of dementia, and we'll be discussing these with the Native American population. And we're also going to describe the 3 stages of dementia. And lastly, we're going to identify the most common ways to diagnose neurocognitive disorders. The PowerPoint is adapted from some HRSA modules and other materials that we have gathered throughout our course of the Dementia Capability Project. The outline is pretty similar to what the objectives are. So we want to talk about the criteria. We're going to discuss the normal ages versus dementia, go through mild cognitive impairment, the early stage of dementia, and the middle stage of dementia. And then we want to discuss the 4 different types of dementias, and those are Alzheimer's disease, vascular neurocognitive disorder, or vascular dementia, Lewy body disease, frontotemporal lobar degeneration, the prevalence, risk factors, signs and symptoms, and rate of progression. We'll discuss the stages of dementia, and we're going to diagnose and discuss the diagnosing of Alzheimer's and related disorders. So, first, let's discuss what neurocognitive disorders are. Like we said earlier, this is the new name, I guess, or the new category that you'll find in the DSM-5. So they've changed the wording from dementia to neurocognitive to include all different types of cognitive disorders. There's quite a few different types of cognitive disorders, but we're just going to focus on those 4. The presentation that we're going to talk about will be those 4: Alzheimer's, vascular dementia, frontotemporal, and Lewy body. So according to the DSM-5, there are certain criteria for diagnosing cognitive disorders, and that is based on cognitive domains. So there's either a mild cognitive domain or major cognitive domain, and we're going to talk about this a little bit later in the presentation too. But whether it's a mild or major, it depends on the significant decline from the previous level of performance in one of these different domains. And these domains are cognitive attention, which is the attention that the person has or their processing speed. And we have executive functioning, which is the ability to plan and make decisions. Learning and memory, which is a recall recognition. Language, which discusses the naming of items and word finding. The perceptual motor, how does a person drive a car? Can they use certain tools? And then the social domain is the behavior on how do they behave in certain social situations. And again, we're going to talk more about this as we go through the presentation itself. So as we age, we may find ourselves having some difficulty with certain areas of those domains. So, such as trying to find the right word or forgetting where we put things. That doesn't necessarily mean that we're going to have cognitive impairment. It can be considered normal aging. To determine if it is normal aging or the beginning of some type of the neurocognitive impairment is how does a person do their normal activities of daily living or their instrumental activities of daily living. So activities of daily living is the ability to perform basic activities such as the bathing, dressing, grooming, the instrumental activities of daily living are things like, how do you do your checkbook? Can you set up your own bills? We're also going to look to see the appearance of any specific behavioral or psychological symptoms, which would indicate that there is something more going on than just regular normal aging, that there is some type of a neurocognitive disorder. So let's look a little bit more at what the instrumental activities of daily living are versus the activity of daily living. So on the left side are the instrumental activities of daily living, the skills that we need to live in a community or live in our house independently. So can we go out and do our own shopping? Can we prepare our own meals? Are we able to go to the store to figure out what foods we need to prepare that meal? Can we use a telephone? Do we know how to call out? And are we able to recognize that the phone is ringing and that we would answer it? Can we take our medications safely, either by setting them up in a medication dispenser or having someone set them up for us and then we take them? And then how do we manage our finances and how do we pay our bills? The instrumental activities of daily living, or the IADLs, are things that we learn later on in life. So when we start to have some memory impairment, these are the things that are going to be lost first. So the activities of daily living are things that we learn earlier on in life, so such as the ability to bathe or shower, the ability to dress, the grooming tasks that we would do, the brushing the teeth, shaving for, whatever, the ability to know when to use the toilet, and the whole tasks that go along with the toileting, able to walk and transfer, and can the person feed themselves? So these are all skills that we learn earlier on in life. These skills will be lost later as the disease progresses. So as people age, we're going to be able to continue to perform those ADLs. So, and we did talk about how the IADL is going to precede the inability to perform the basic ADLs. One of the first things that we may notice as a person's cognitive impairment progresses is that the ability to manage their finances. That seems to be one of the first IADL changes that will suggest that there's some cognitive decline. We are maybe become a little bit more forgetful as we age. Some of that forgetfulness, again, can be normal aging. We might need a little longer to remember things. That can be considered normal aging. We might get distracted easier. Sometimes we might forget to pay our bills. Just because we are forgetting some things, maybe not being able to remember to go to the appointment unless somebody calls us, or getting distracted. Some of this stuff is considered normal aging. So it is common to be a little bit more forgetful, and we may need a little longer to remember things, such as forgetting to pay bills. So just because we have some of these things that are listed here does not necessarily mean that we have cognitive impairment. So we do know that normal aging leads to change in all 5 senses. There can be some visual perceptual difficulties that develop along with some hearing problems. There can be some age-related problems with speech and language, which can be associated with hearing. There are also changes in taste and smell that's associated with normal aging. So one thing to remember is just because there's some forgetfulness in normal aging, that does not mean that we're going to develop dementia. One way that I like to think about, the difference between normal aging and cognitive impairment is if you're going to go to the grocery store. So if you go to the grocery store and you're like, okay, I'm going to make a list of things that I need. So I'm going to put on my piece of paper, then I'm going milk, bread, and cereal. So I put that in my pocket and I get to the store. So with normal aging and some normal aging memory impairment, I guess, you get to the store and you're like, I can't remember what I was supposed to get, but I look in my pocket and I find my list and I know my list is in there, and I look at my list and it says milk, bread, and cereal. So I go buy milk, bread, and cereal. If you're starting to have some cognitive impairment, you get to the grocery store, you don't remember that you have a list, you don't really remember what you're doing there. You might not even be at the grocery store. But if you do get to the grocery store, you're going to purchase stuff that you probably don't remember buying, that you were supposed to buy. So that's kind of how I like to think about normal aging and some cognitive impairment. So we also have what we call mild cognitive impairment. And mild memory impairment, again, is not a normal sign of aging. So mild cognitive impairment, or MCI, is a condition where there are some memory problems that begin to develop that are greater than what is expected for age. So if you go to the normal aging impairment that we were talking about earlier, some of that normal aging memory loss that they have, you can still continue with your normal life. So as we start to move into the mild cognitive impairment, we might see that there is some kind of impairment and a little bit more impairment in those ADLs. So just to kind of talk a little bit more about MCI, there is no single cause for mild cognitive impairment. It can occur from diabetes, it can occur from strokes, can be some genetics, and we'll talk about that when we get to some of the different causes of dementia, types of dementia. It can even be caused from smoking or alcohol and drug abuse. Mild cognitive impairment can affect 10 to 20% of those over 65. Again, can usually care for ourselves, usually can do our own normal activities, might just take us a little longer to get to what we're wanting to do. We don't see any personality changes with MCI. We will see that sometimes the person does forget to go to some important events or appointments, or they might lose things. There might be some difficulty finding the right word to finish their sentence. But again, as with normal aging, not everyone that has MCI is going to develop Alzheimer's disease. So let's kind of look at the different types of, the different stages of dementia, I guess. So with dementia, we're going to see some difficulty with memory, and that's kind of memory loss. Forgetfulness is like one of the first signs that we're going to see with memory impairment. There might be some difficulty with language, problem solving, any other cognitive issues that start to affect everyday life. So remember, with normal aging and with MCI, the normal day-to-day life really isn't affected that much. You can continue to live at home by yourself. You can continue to do your same daily activities. Sometimes now, as we start to see a progression, moving from MCI into the different stages, we're going to start to see some cognitive behaviors or issues that are going to affect a person's day-to-day life. Most of the dementias that we're going to talk about are progressive, and there are 3 different stages. There's mild, moderate, and severe. So mild sometimes is called the early stage, moderate is sometimes called the middle stage, and then the severe stage. So let's look at the mild, early stages of dementia. So there are more serious cognitive difficulties that we're going to see with just the mild cognitive impairment that we talked about. So starting to progress a little bit more with some cognitive difficulties, such as the memory loss might be a little bit more. The ability to find that proper word to use when they're talking, identifying maybe the difference between salt and sugar. Might want to say sugar, but they say salt. Might start to see a little bit of behavior changes in the mild stages. And then there's some multitasking. That person used to be a very good multitasker, now kind of starting to see that they have to have those tasks broken up into maybe more simple tasks instead of that multitasking that they used to do. So starting to have some more difficulty, like we said, with everyday activities than we would see in mild cognitive impairment. So this is a slide that's kind of got lots of information on it. And this is from Nestle's, actually, from their health science department. And on the left side, you can see this is mild cognitive impairment. And then on the right side, it talks about early dementia. Down the middle is the different tasks and different things that we'll see in somebody who's having some cognitive impairment. So let's just kind of go through these briefly. So in the memory category, under mild cognitive impairment, might find some difficulty in recalling information like phone messages, shopping lists, and appointment dates. With early dementia, there's going to be more difficulty in remembering recent events and maybe not recognizing some of the people that are around them. With language, mild cognitive impairment, some difficulties in finding the right word. Early dementia, maybe some more major difficulties in finding the right word to say. With problem solving, with MCI, difficulty in adapting to changes in a particular routine. So we talk about the importance of keeping things similar, keeping the same kind of structure, keeping the routine pretty similar. That will really help with helping with problem solving and help with some of the behaviors, and we'll talk about that later on too. So with early dementia, they might find that handling tasks such as doing finance is very challenging. Kind of like we talked about, one of the first things we're going to see with those IADLs is the ability to handle finances. The sense of time and direction with MCI, the person might be aware of their surroundings, but they have difficulty judging distances when they're driving. They sometimes lose track of time. With early dementia, finding unfamiliar locations, being able to find an unfamiliar location is difficult, and often the person will lose track of time. Multitasking, mild cognitive impairment, maybe some difficulty coordinating tasks, but still can manage those tasks alone. Early dementia, they might start to see that socializing is a little more difficult, a little more harder to stay in the conversation, and it's going to need some help with coordinating tasks. With the personal care under the MCI, able to look after themselves. Sometimes they might feel a little anxious, not knowing, realizing that maybe they are kind of starting to forget some things. As the disease progresses, if it does progress into early dementia, they might need some reminding and some assistance with some of those ADLs, and they might start to see a little more emotional disturbance, maybe a little more disinterested in what's going on around them. So now we have the moderate to middle stage dementia, and it is important to know that as a disease progresses, there really is no distinctive transition between stages. Mostly there's a progression or difficulty that you'll start to see. So the might be an increase in the memory impairment as we start moving from the mild stage to the middle stage. The middle stage or the moderate stage is typically the longest stage. Still may be able to live at home, but they might need some assistance with certain things, safety being the big thing. So can the person live at home safely? Are they starting to wander outside in poor weather conditions? Trying to drive their car, trying to get someplace and can't get there, so they get lost. So you can hear about some of these things in the news and things like that. So it's really safety is our biggest concern as a disease progresses, especially in that moderate to middle stage. And again, this stage does tend to take the longest. Okay, some more things under the moderate stage: increased memory loss and confusion. Might start to see more of a short of attention span. Inappropriate angry outbursts, starting to see maybe some more behavioral issues. The problem recognizing family and close friends might start to occur in this stage. A little more difficulty with language, trying to find the right words to say, and trying to understand what is being said to them. So the processing might slow down, the two different parts of communication, the comprehension and the processing. So might be not able to understand exactly what is being said, might take a little bit longer to process what they're hearing, and it might take a little longer to comprehend what's being said and then what they would like to respond to. So there'll be some difficulty learning new things. And this is where we talk about the importance of keeping things structured and pretty repetitive. We might see some repetitive statements or movements, so continually asking the same questions. We talked about the inappropriate angry outbursts and some of those behaviors that we're going to start seeing. Some other behaviors that one might see is some restlessness, the agitation, the anxiety, and the wandering. And that's where we have to start thinking about the safety concerns. Is there safety issues of the person wandering outside? Are there some hallucinations, some delusions, suspiciousness, paranoia, irritability, impulsiveness? So it is, person might become more physically or verbally aggressive. And as we go through these different stages, it's really important, as the person goes through the stages, it's really important to keep the family up to date and their care team, their loved ones, so that they know that this is part of the disease and it's not being directed at them. Family and friends who are caregivers might tell you that this is harder on them than it is on the person with the dementia, or just as hard. And we might see that it is really difficult if the person doesn't remember who they are, or they don't recognize them. It's important to know when we start talking about the hallucinations and delusions that it's not something that's medication related, or that they're not having delirium from a dehydration or an infection or something. So we need to make sure we rule that out. And when we get to the diagnosing part, we'll talk a little bit more about that. They may have some inability to carry out activities that require multiple steps, such as the multiple steps in dressing. Putting on your underclothes and then putting on your pants or your shirt or your dress or your skirt or whatever, and then putting on your socks and putting on your shoes. It kind of takes a few steps. So laying those steps out and putting those steps out one thing at a time. Same thing with setting the table, one thing at a time. Maybe can't remember or, to put the plate down, the cup, the glass, the spoon, the fork, the knife, so. And then, like I said before, that this is often the longest stage. As the stage starts to progress into the more severe stage, there's going to be a need for a higher level of care that maybe the caregiver can't provide, so they might have to start looking at adding some additional caregivers in the home, or is there an admission to a facility that might occur? Oftentimes in the Native American population, there's multi-generational families living in one home, so they might see that the children might be caring for their parent, and their parent is the one that has the dementia. And the grandchildren might also be involved in the care, so educating and making sure everybody in the home is aware of as the disease progresses and the things that might be occurring. Okay, the last stage is the severe stage. Here we might see a decrease in appetite or the ability to chew, which can result in some weight loss. With weight loss, possibly if the person is not as mobile as they used to be, there could start being some skin breakdown or some skin infections. The person may experience some seizures as the changes in the brain occur, not always, but sometimes. Verbal language here might be more groaning, moaning, or grunting, so not being able to produce the word. But we do know that if there is some groaning and moaning or grunting going on, that the person does need something, so we have to figure out what it is exactly. And we'll talk about some of that when we get to part 2. The person might sleep more, and that can also cause some problems with skin infections, so we might have some problems with weight loss because of difficulty swallowing. That might have some increased sleeping, not being able to be as mobile as possible again, and then that can cause some skin breakdown. So as the person doesn't get up as much, we can also see some respiratory infections. So frequently, it's a respiratory infection that is the cause of the person passing away, usually a pneumonia or some type of respiratory, like we said, infection, because of the inability to take those deep breaths and to get up and move around and to cough and get that mucus out of their lungs. And we do see the inability of bowel and bladder functioning is lost. Usually the loss of bladder occurs before the loss of bowel, because in our developmental stage, when we start to learn how to control our bowels and bladder, we learn how to control our bowel before we control their bladder. So if we think about as the memory fails, it kind of goes backwards. So the first thing or the last thing that you learned is the first thing forgotten. So if you learn how to control your bladder after you've learned how to control your bowel, then you forget how to control the bladder, and then you lose that bladder incontinence, and then you have bowel incontinence. So oftentimes it's the loss of bowel and bladder that makes that caregiver realize that they cannot keep up with the person who has dementia. So oftentimes if there is going to be placement in a long-term care facility, it happens in the late moderate stage and into the severe stage. But not everyone with dementia is admitted into facility. Many of those with dementia can stay at home, depending on their level of support. Like we said, those multi-generational families that can provide some support, use of home care agencies. I know out on Spirit Lake, we have a QSP, or a quality service provider agency, that similar to a home health agency, and they can come out and do some caregivers. There's also some CHR, so public health. So looking at the resources that are available in the community, it really is in the person's best interest, the person who has dementia. It's in their best interest if they can stay at their home, because it is familiar to them. And if they do get admitted to a long-term care facility, we might see that there's a rapid progression of dementia, or of the memory impairment. Okay, so like we said, the term dementia was replaced with the DSM-5 for neurocognitive disorders. However, because dementia is such a common term and recognized more than the term neurocognitive disorders, we still are using the word dementia. So this is a dementia umbrella, and this is courtesy of the Alzheimer's Association. So under their umbrella, they talk about the 4 different types that we're going to talk about. So, and those are Alzheimer's, vascular dementia, dementia with Lewy body, and frontal temporal dementia. So you might see this umbrella used in some of the Alzheimer's associations marketing and on their website and things like that. So, okay, so when we talk about neurocognitive disorders, and we talked about this a little bit, that they're either referred to as major or mild, and it depends on the severity of the symptoms. So we have Alzheimer's disease, and then we have a vascular neurocognitive disorder, which is frequently referred to as vascular dementia. Lewy body disease, which we frequently refer to as Lewy body dementia. Frontotemporal degeneration is what it's called in the DSM-5, but that's frequently referred to as frontotemporal dementia. Used to know it as frontal lobe dementia, also can be sometimes thought of as early onset dementia. The other neurocognitive disorders that can cause memory impairment are traumatic brain injury, and we're not going to talk a lot about that, but just to know that in the Native American population, there is a higher incidence of traumatic brain injury. If the traumatic brain injury does occur at a younger age, that can be a precursor to somebody developing some type of dementia. So there's substance medication abuse that can cause memory impairment. Parkinson's disease dementia, which we're going to talk about when we get to the Lewy body, because that kind of goes hand in hand with the Lewy body dementia. Huntington's chorea, which can also is a kind of a neuromuscular disorder, can cause some confusion, some dementia. Down syndrome, if it's I think that at one point in time they had identified if it's a trisomy 13 that causes a Down syndrome, that can be a marker for memory impairment. And then someone with HIV. So these are just a few of the other neurocognitive disorders that are in the DSM-5, but we're not going to spend a lot of time on those. Just be aware that there are some other disorders that can cause some dementia and some memory impairment. Okay, so here's this little dementia pie that kind of gives you a little bit visual of, the significance of the different diseases. So we have Alzheimer's disease, which is the most common type of dementias, one of the most common types of dementias. Then vascular dementia is the next one, and that's in the lighter blue. And then you can have mixed, which means you can have vascular dementia with Alzheimer's, or you can have Alzheimer's with Lewy body, or just a mixture of different types of dementias. So you can't really identify exactly which one it is. So then we would put that in the mixed category. And then we have dementia with Lewy bodies. The other category can be those other types of dementias that we talked about, such as the traumatic brain injury, the substance abuse, Parkinson's dementia, and then the rarest type really is the frontotemporal. Okay, so dementia among our indigenous population. So in some Native American language, there is not a word for dementia, which could contribute to the rise of the numbers of diagnoses among the Native American population that we're starting to see. As many as 1 out of 3 Native American elders will develop some type of Alzheimer's or other form of dementia. One of the issues faced by the Native Americans and or Alaska Natives is that they may not be diagnosed with dementia due to the lack of access to healthcare. And because there wasn't a word for dementia and it wasn't really recognized, they may not have gone to see their provider to get the actual diagnosis of dementia. So we are starting to see that there is a rise in the Native American population of those diagnosed with dementia, which is what has led us to this grant, which is supporting this presentation, the Dementia Capability in Indian Country. So just to kind of give you a little bit of statistics, I guess, in the 19th and 20th century, the Native American population had shorter lifespans. And since dementias are mostly a disease of aging, the occurrence of dementias was rarer in the Native American population if they didn't have a long lifespan. So now we're seeing that Native American lifespans are starting to increase. So that Native Americans are becoming more likely to reach the age where Alzheimer's and dementias will occur. So compared to the 1970s, where 4.8% of Native Americans were over 65, now we're up to 15%. So that's quite an increase of those that are 65 and older. So like we said, with this being a disease of the aging, now we're starting to see more of that, those diseases occurring in their Native American, Alaska Native population. By 1960, they're projecting that the number of American Indian and Alaska Natives age 65 and older living with dementia is projected to increase fourfold. So the awareness that we need to have out in the Native American and Alaska Native communities on what are the resources, how do we diagnose, what can we provide, how can we prevent, if we can prevent, how can we slow the progression down is very important. So the Native Americans' perceptions of Alzheimer's and dementia. So as more of the Native Americans are being diagnosed and the term dementia is becoming used more often, the perceptions of Alzheimer's and dementia is kind of interesting. So we find that 65% of Native Americans say that they know someone with Alzheimer's or dementia. And I think when we go out to Elders Day out at Spirit Lake, which is, in kind of the center part of North Dakota, that when we're talking with some of the elders, they'll frequently say, my grandmother had this, or my grandfather had this, or my auntie or my uncle, and didn't realize that maybe it was Alzheimer's at the time, but now knowing the signs and symptoms of Alzheimer's are saying, yeah, I think they had that disease. So 65% feel like they know somebody with Alzheimer's or dementia. 25% of Native Americans are worrying about developing some type of dementia or Alzheimer's. 35% of Native Americans say that they don't think they're going to live long enough to develop Alzheimer's or dementia, which I think is kind of interesting. A common misconception, and I think this is kind of true across the board, is that memory impairment is a part of aging. Then we find that 53% of Native Americans believe this to be true. When they've done research on Alzheimer's and dementia, when you're doing research on Alzheimer's and dementia, it is really important to include different ages and ethnicities. So over 50% of Native Americans do not want to be part of any type of clinical trial because they feel like they're being used as a guinea pig. So when we talk about clinical trials, we're talking about the medications that we can use that they're finding that might slow the progression down. Back in the old days when they did clinical trials, most of the clinical trials are done on healthy white men that were 35 to 40 years old. So not including elderly men, not including younger people, not including women in the studies. Now when they do clinical trials, they're trying to do clinical trials across, the different ages and ethnicities. But they're finding that over 50% don't want to be part of those clinical trials. 36% of Native Americans don't feel that's going to be benefiting them at all. 31% feel that it's going to take too much time and it's going to cost too much to be part of the trial. They might have to have transportation to the clinic where the trial is being performed. And 26% do not trust that the drug company is going to perform the clinical trial. Okay, so this is a slide this is from the Centers for Disease Control and Prevention, that there's an estimated 6.5 million people living with Alzheimer's, which is the most common type of dementia. That number is expected to increase by 2060. They feel that the largest increase is going to be among the non-Hispanic, Black or African American, and Hispanic or Latino adults. The prevalence of memory impairment between the years of 2015 to 2020 was 5% of Asian and Pacific Islanders, 9% of non-Hispanic whites, 10% of Black adults, 11% of Hispanic adults, and 16.77% of Native American and Alaska Native. Okay, so we're going to start talking a little bit about the various types of dementia. So we're going to start with Alzheimer's disease. So Alzheimer's is the most common type of dementia. It was identified in 1906 by a German psychiatrist and neuropathologist, Dr. Louis Alzheimer. So what happened with him, or how he diagnosed this, is that he had a patient who died of an unusual mental illness. The symptoms that patient was having her symptoms were language, memory, and she was having some behaviors that were kind of unusual from the other types of clients that he saw in his psychiatry practice. So he decided to perform an autopsy on this patient, and he identified in the autopsies were those neurofibrillary tangles that are kind of a hallmark symptom of Alzheimer's disease, and the tau tangles. Those can, we used to say you can only see those on an autopsy, and that's still kind of standard, is that the best way to determine which type of dementia or Alzheimer's that the person has is on an autopsy. So the neurofibrillary plaques and the tau tangles are the hallmark symptom for Alzheimer's disease. There's also a genetic marker that can possibly predict if a person is at risk for Alzheimer's. And they've just found, they've been doing an awful lot of research on Alzheimer's and dementias, and they have found that there is a marker, and it's called APOE4. So everybody gets an APOE protein from everybody gets an APOE gene. Let me just say that. You get one from your mother and one from your father. So we all have an APOE gene. We should have two of them, one from our moms, one from our dads. So whether we get the APOE 1, 2, 3, or 4 just depends on which is passed genetically from our parents. So the APOE makes a protein that helps carry cholesterol and fats to the bloodstream. So what they're finding is that there's a possibility that there's a problem with the brain cell's ability to process fats or lipids, and that might play a role in Alzheimer's. So they're trying to see if there's a way that they can affect that APOE gene to help with breaking down the fats and lipids so that they don't cause constriction in the blood vessels and things like that. So if we're remembering now that we each get one APOE gene, if somebody has an APOE4, that is what they're finding, that 25% of people will carry one APOE4, and 2 to 3% will carry 2 of the APOE4 gene. So it's the APOE4 that is a marker that is being found in those with Alzheimer's. So, but remembering not everything's an absolute, so just because you have an APOE4 gene doesn't necessarily mean you're going to get Alzheimer's. If you have 2 of the APOE4s, so you got one APOE4 from your mom and one APOE4 from your dad, so now that gives you 2 APOE4 gene, that is you have a higher risk factor of having Alzheimer's disease. So they're trying to do some work on this whole cholesterol carrying APOE. So what's interesting about this is that with the Native American population, they are kind of almost immune to the APOE4 gene because of their history, of their diet history from the past. And probably sometimes I get ahead of myself, so I apologize if I say this now and then I'll repeat it. But so they have found that because of their dietary habits from quite a long time ago has actually made them kind of immune to the APOE for that cholesterol and fat carrying gene or protein. So, okay, I hope that wasn't too confusing. So just to let you know that there is in the very middle of the brain, and you can see it on the picture here, there is the little sign or little arrow there that points to the hippocampus. So the hippocampus is responsible for language and memory, has a huge role in that. It's one of the brain areas that's affected in Alzheimer's first. So when we talked about there being forgetfulness, that's where it starts. So it starts in the hippocampus, and then it'll start to spread out through the rest of the brain. Okay, so continuing on with Alzheimer's disease, we find that the greatest risk factor, like we talked about, is age. It can start as early as the mid-60s, and the risk factor does go up with age. It is considered a terminal disease, and at this time it is the 6th leading cause of death. Depending on when the disease is identified, from diagnosis to death can be as little as 3 to 4 years, or can be as long as 10 years. I've taken care of people who've had an Alzheimer's presentations for up to 20 years. There is no cure for Alzheimer's. We did talk about the plaques and tangles. Those plaques are called beta amyloid plaques. And beta amyloid is that protein that forms the sticky plaques on the brain, and it starts to cause those brain cells to die. So there are two well-known ways to identify if there are plaques in the brain, and we did talk about the autopsy, but they're also seeing that maybe there is a I forgot what I was going to say, that there is a blood test that can identify the plaques. You can possibly get to the, by doing a spinal tap, you can identify if there's some plaques in the brain. And then there's a PET scan, and we'll talk about that in a little bit here on what it looks like on a PET scan. I did want to show you on the left side, or talk about on the left side of this slide, you can see the very early Alzheimer's. The frontal lobe is the front part of your head, kind of your forehead. The parietal lobe is the top part of your head, and the occipital lobe is in the back. The temporal lobes are by your ears. So each one of these are going to be affected differently as the disease progresses. But you can see that there is starting to be, like, the brain starts to almost shrink. And that's because it does kind of shrink. The brain cells start to die, and there is some shrinkage of the actual brain. So it does affect pretty much the whole entire brain. Okay, how does Alzheimer's change the brain? There's a YouTube video here that I won't be able to play on here, but you might want to look that up, and it gives you a good, definite explanation of how those tangles and plaques occur and how it affects the brain. When we talked about it being from diagnosis to the end of life, it can be very slow decline. It's kind of like going down a hill. So it can take, that hill can take 3 years, can take 5 years, can take 10 plus years before it becomes end of life. So again, some pictures of the changes in the brain. One thing that you can see is that there's becomes a space, those spaces between, I don't know exactly what you call them, but if you look on from the difference between the healthy brain on the left side to the severe Alzheimer's brain on the right side, you can see that the brain has shrunk, and that in between there's been some grooves, some spacing that is causing the memory impairment, the brain death that's occurring. So, okay. The Centers for Disease Control and Prevention has a guide that is focused on dementia in Indian country, and it's called the Healthy Brain Initiative Roadmap for Indian country. And in that document, there are the 10 warning signs for Alzheimer's in their roadmap. So the first warning sign is memory loss that disrupts daily life, such as forgetting events, repeating yourself, or relying on more aids to help remember, like sticky notes. The second warning sign can be challenges in planning or solving problems, having trouble paying bills or following familiar cooking recipes. Third, difficulty completing familiar tasks at home, work, or leisure. This can be having trouble cooking, driving to familiar places, using a telephone, or doing some shopping. The fourth, confusion with time and place. We might see some trouble understanding an event that is happening later on, not knowing, losing track of the dates and times. Maybe they're going to go to a powwow that always occurs at the end of July and just can't remember that that's going on. Number 5, trouble understanding visual images and spatial relations. This can be having, we might see more difficulty with the person with balancing, judging distances, tripping or spilling, dropping things more often than they used to. Number 6, new problems with words and speaking or writing. This can be having trouble following or joining in a conversation, having difficulty finding the right word or identifying items. Not being able to realize that this is a pen or a pencil or a marker or a crayon or something like that. Number 7, misplacing things and losing the ability to retrace steps. So just trying to find your items, such as your car keys. You might find your car keys in the washing machine or in the dryer. Aren't able to retrace your steps to find the lost items. So frequently, if we lose something, like if I misplace something, I can backtrack and think, okay, where did I put that? And be able to find what I'm missing. The person that is starting to have some Alzheimer's is not able to backtrack because they can't remember where they were at. So decreased or poor judgment. And here we need to worry about them becoming a victim of scam phone calls, things in the mail, giving out social security numbers, giving out credit card numbers, just being kind of victimized from scams, I guess. Not being able to manage your money very well, starting to pay a little bit more, paying less attention to personal hygiene. And if they do have pets, they might not be able to remember to take care of them, not being able to feed them. So that might be something we have to keep in mind. Number 9, withdrawal from work or social activities, not wanting to go to favorite events, not being able to follow basketball games or keep up with what's happening in the basketball game or the social event. Starting to see some changes in mood and personality, and we talked a little bit about that. Starting to get some, see some irritability, some suspiciousness, being fearful in common situations that they used to enjoy going to. Okay, this picture we're going to see a couple times in this presentation. This is compliments of the Alzheimer's Association from Calgary, Canada. So if you kind of look at what the different things are under each one of the lobes, and we'll just briefly go through those. So like the frontal lobe, that's kind of where our filters are. How do we solve problems, our reasoning and our judgment? If we're outside and it's hot, we don't just take our clothes off because we know that we're not supposed to do that. The temporal lobes, there's 2 of those, one on each side of the head. This is where language, being able to understand language and behavior. Again, memory can be impaired here, but this is kind of where the hearing also can be affected. The parietal lobe, knowing right from wrong, being able to read and comprehend, orientation of your body in where you're at, where you're walking. That balance problem that we talked about can be part of the parietal lobe, but it can also be part of that cerebellum, which is that little purple area down there at the bottom. The occipital lobe, vision and color perception. Each one of these lobes are affected differently at different stages of the disease, just depending on which disease it is. The brainstem, not really affected. The brainstem, does connect to the spinal cord, so the brainstem is probably one of the last areas that's affected. And this is where, when we talked about how Alzheimer's is the 6th leading cause of death, because the breathing will slow down, body temperature changes, ability to digest, increased amount of sleepiness, not being able to get up, not being able to balance yourself, not being able to walk. Swallowing can also be an issue in this section. So just a nice little visual so you can kind of see what goes on in the brain as the disease progresses and how each of these things are going to be affected. Okay, so now let's move on to vascular dementia. This is considered the 2nd most common type of dementia. It usually occurs in the late middle 60s and increases with age again. This can occur alone or can occur with other forms of dementia such as Alzheimer's disease. So we talked about the slow going down a hill kind of progression that we'll see in Alzheimer's disease. For vascular dementia, it's more of a stepwise decline. So you can kind of see there's like a little step up there on where that says vascular dementia. So it kind of plateaus for a while, and then there might be a little event that occurs, such as a stroke, and then you have a decrease in functioning, and then you have another plateau, and then you have another event that occurs, and then you decrease, and then you'll have another plateau. So it's more of a stepwise decline versus that slower progression. So some of the things that they have found with vascular dementia is that it's caused by different conditions that can interrupt the flow of blood and oxygen to the brain. So we're talking about the vessels and the vasculature of the body. And that's why it's called vascular dementia, is because if there is some type of a disorder that is causing the blood flow to be interrupted, such as a stroke, such as a blood clot, diabetes, having too much sugar in those blood vessels where it makes that blood vessel get smaller and smaller, so you have less amount of blood going up to the brain. Smoking can cause the same damage to the blood vessels, just making it so that you cannot get the blood flow to the brain. No blood flow to the brain, you have brain death. Loss of oxygen to the brain because oxygen is carried by the blood, so increase in confusion. So they have found that there's a very strong link with cardiovascular disease, such as high blood pressure, high cholesterol, and obesity that can be, cause difficulties with that blood getting through those vessels, the cerebral vascular systems, the strokes. What they have found is that there is no known cause for Alzheimer's disease, and you can't cure Alzheimer's disease, but they're thinking that maybe you can stop vascular dementia. So you can almost always see the damage to the brain on an MRI, such as those strokes. So kind of what we were saying, here's what happens. The blood clot, there's a blood clot in the blood vessel. It prevents blood from getting through. There's too much sugar in that blood vessel. It prevents blood from getting through. There's damage from smoking. So they are seeing that the main difference between vascular dementia and Alzheimer's is that the cause of vascular dementia can be prevented. So main causes are those transischemic attacks, those TIAs, strokes, hypertension. So if you can maintain or manage hypertension, manage and maintain a good blood sugar, all of those lifestyle changes, you can actually prevent the occurrence of vascular dementia. Once vascular dementia occurs, there is no cure for it. But if you start changing some of those lifestyle, making some of those lifestyle changes, that can really reduce the impact and severity of the symptoms. So it can slow the progression down. So what we want to tell our elders is, to keep those blood sugars under control, keeping your blood pressure under control, to prevent the formation of clots, to prevent strokes from happening. So the important part of the vascular dementia is that, yes, it can be, they are finding that it can be prevented if there are those lifestyle changes that are going to occur early on in that person's disease. So they're being diagnosed with diabetes, trying to keep that diabetes under control for their lifespan, so they don't get the vascular dementia that might occur from that. So, okay. So those are the first two types of dementia. The third type we want to talk about is Lewy body disease, or dementia, or LBD. You might see it called by. This usually occurs later on in life, and this one actually has two different types of dementia associated with Lewy body. So, with similar symptoms. So the two different types are Lewy body dementia and then Parkinson's disease dementia. So earlier on we had talked about some of those other types of diseases that can cause some dementia, Parkinson's disease being one of them. They're seeing that Parkinson's disease dementia and Lewy body dementia are similar. The main difference is what happens first. So with Lewy body dementia, the person is going to have the confusion, the dementia, before they start seeing the movement disorders. And those movement disorders are similar to what you would have in Parkinson's disease. So if the dementia and the confusion occurs a year prior to the movement disorder, then the person's diagnosed with Lewy body dementia, or should be diagnosed with Lewy body dementia. If they start to see that the person has Parkinson's disease and they've had the movement disorders that goes along with Parkinson's and the changes that go along with that movement, and then a year later they start to have some confusion and some dementia, then that would be considered Parkinson's disease dementia. Both types are going to have similar cognitive issues, the same type of physical problems, same sleep disturbances and behavior problems. So it's pretty, the signs and symptoms are pretty similar. It's just when you are trying to identify which one it is first, does the confusion come before the movement disorder, or does the movement disorder come before the confusion? So there's some visual hallucinations that will occur with this, and interestingly, often those visual hallucinations involve children. So the hallmark symptom of Lewy body disorder is the fluctuation of cognitive functioning. So you might see one day that the person is functioning really well, and then the next day they can be totally disengaged with a profound loss of memory. So I think about the book, I think it's called Still Alice. No, The Notebook. I think it's The Notebook, where I'm just thinking about the movie where James Garner comes in and he's going to see his wife and he says, maybe today's the day she's going to recognize me. So, when you start looking at some of these different types of diseases, you think, I wonder if that was Lewy body, where one day she can recognize him and the other day that she can't, So just that, and I hear this from families that say, boy, yesterday I came to see them and they were doing great. They knew who I was. We had a great conversation, but today they don't. So that's that fluctuation of cognitive functioning can be very disheartening for the family. Very difficult.